Welcome to this edition of Perspectives in Inflammation podcast, a series brought to you by the CSF, a cytokine signaling forum, which shines a spotlight onto experts in the field of inflammation and their research interests. My name is Valderillo Azevedo. I'm from the Federal University of Paraná in Brazil. And join me today is Dr. Enrique Soriano from the Hospital Italiano de Buenos Aires, Argentina. Welcome, Enrique Soriano. It's a pleasure to have you here, as you're a great friend. We have been working together for so many years.
Yeah, thank you, Valderillo, and thank you for this invitation, and thank you, CSF, for inviting me to participate in this podcast. And well, it's a great pleasure to talk with you, Valderillo.
Well, Enrique, I know that you have been working at the Hospital Italiano, Buenos Aires, now for about 30 years. It's a lot of time, right? 30 years.
That talks about my age.
I'm figuring out how old are you.
Yeah, don't make any maths.
Yeah. Can you tell us about the institution you work and the clinical and research programs there? A little bit about your interests, please.
Yeah, thank you. Well, the Hospital Italiano Buenos Aires is one of the largest hospital, probably is the largest hospital in Argentina. It's a private hospital, but it's a university hospital, so it has its own university, and it's a very large with all these specialities. It's around 700 beds, and we see more than 100,000 patients per month in the outpatient clinic. So it's very large and is very well known. And when you start in this hospital, I did my internal medicine residency here. It says that it has 3 pillars, and one is the assistance, so to see and to treat patients in the best way, but the education and the research. So those are the 3 pillars here. So since you start here, research and education are very important parts of your life here in the Italian hospital. So and that's something that always attracts me.
Yeah, you're now, of course, the head of the rheumatology unity. I know that, and you are the chair of PANLAR. You're the chair of PANLAR, the president of PANLAR, and I would like to discuss your current positions further, of course. But before I do, I would like to turn back the clock a little to find out what first attracted you to the field of rheumatology. What has motivated you at the beginning to become a rheumatologist?
Yeah, when I finished my, as many of us, I don't have any exposure to rheumatology during my medical career. I studied at the Buenos Aires University, and during my internal residency, I started seeing patients with rheumatic conditions, and that attracted me. And also the head of the rheumatology unit at that time was Dr. Catorjo, a very well-known rheumatologist that has trained abroad and has a lot of interest in research. So that also attracted me. So when I finished my internal residency, he offered me to stay as fellow. And I accepted because I like it, and as many of us, that the rheumatology is a very clinical specialty. So you keep many of the clinical characteristics of the clinical knowledge you acquire during your internal medicine residency, and you keep that along your career. So I still like that. The patients have a lot of challenges. They are difficult patients. They are they need the opinion of different specialities. And so as we can see now, even the COVID-19 seems to need rheumatology for that, some of their treatments. So I think it's, so that attracted me at the beginning. And that's why I choose to do rheumatology, and I'm very happy of my what I choose at that moment. Yeah.
And as a rheumatologist, of course, you had the opportunity to influence other rheumatologists in your country, right? Some other young rheumatologists, they
we
try to follow your career, to follow you.
Well, we have a large fellowship here. We have 9 trainees here, 9 fellows, and we have, in these last 30 years, we train a lot of rheumatologists that are now spread around Argentina and even from some other countries. So yeah, and the thing that we try to pass to them is this enthusiasm for the patient, their complex disease, and also to try to do some research. We mainly do clinical research, but the research for us is very, very important.
Looking at your field of knowledge, you have a number of key areas of interest within rheumatology, including disease prevention, the role of ultrasound in prognosis and pathogenesis, especially in psoriatic arthritis also. In your review published last year titled Interventions on Modifiable Risk Factors for the Development of Psoriatic Arthritis, you discuss current evidence for interventions that have the potential to prevent psoriatic arthritis. That's very interesting. Could you give an overview of the interventions of interest and which of these interventions you believe to be the most promising for patients?
Yeah, I think the one thing that I've been thinking not only me, but a lot of other people, is that, well, we are improving a lot in the treatment of our disease. We have new drugs, we know a lot about the cytokines involved, but at the end of the day, and I think it's more and more evident that many of our patients that are doing great, we are unable to stop the medication. So we are treating the disease, but we are not stopping, we are not curing that. And I think that some focus we should have is trying to prevent the development of this disease. And that's something I'm trying to get more and more involved, how we can pick up these patients before they develop the disease, and whether we can stop that. So that's why I reviewed a little bit the literature there in psoriatic arthritis. And there are some things, not that many, but treating obesity, for example, is something that have been shown that can prevent patients with psoriasis to develop psoriatic arthritis. And I think the fields that are coming now is whether treating the subclinical enthesitis will do some change, or treating very aggressively the psoriasis itself might prevent development of psoriatic arthritis. In that sense, we are presenting an abstract in GRAPPA this year, showing that in a large cohort of patients with psoriasis treated with different ways, topics versus traditional DMARDs or biologics, those patients that were treated with biologic had a lower incidence of psoriatic arthritis. So I think that in some way, not only for psoriatic arthritis, but for many of the other diseases, I think that to try to find biomarkers and try to prevent those patients to the development of the disease is the way to come. I think is what we should focus in the next years. And that's something I'm trying to do. And ultrasound plays some role there to detect subclinical enthesitis as well. So that's why we are also have a large group doing ultrasound, and we have been doing some research related to the role of images and ultrasound in the assessment and also the prevention of these diseases. So yeah, it's a field that I think it's very important.
Yeah, you talked about obesity, the prevalence of obesity in psoriatic and also psoriasis patients is very high. Yeah, but obesity by itself is inflammatory status. But in your opinion, talking about other non-pharmacological interventions, what do you think can we anticipate to the patients? Like for example, smoking. We have a lot of discussion about smoking. Is it a risk factor to psoriatic arthritis or is not?
Well, I think there are contradictory results. There are a couple of studies that show that it's a risk factor. There are those studies from Daphna Gladman that are showing that it's a protective factor. So it's quite difficult to say. I think that probably we usually not only because of the disease, but also because of all the other bad things related associated with smoking, cardiovascular disease, that is also a risk factor, and is increased in our patients with inflammatory conditions. I think we try to encourage patients to stop smoking. So I think from the modifiable things we can do is mainly, well, try to treat obesity, stop smoking are two important ones, and the stress on the enthesitis and this is also something that should be looked into. We didn't encourage people to stop doing exercise. We encourage them to do exercise, but perhaps if they had contact exercise or very hard exercise, well, perhaps that's not as good.
The psoriatic arthritis requires a very good physician, a very good clinical background, because you have to look at hypertension, you have to look at dyslipidemia, obesity, so many other factors you have to look at. Because not only you have to be constant, have to be pharmacological treatment, but to look at the patient as the entire organism. But a number of publications. Sorry.
No. I fully agree.
Yeah, a number of publications focus on the use of ultrasound. Looking back the ultrasound to the ultrasound in the prognosis and pathogenesis of psoriatic arthritis. Could you give us a little background on an investigation you have published in 2017, if I'm sure, where you investigated the value of power Doppler, that it's important, power Doppler ultrasound, for predicting short-term flares in patients with psoriatic arthritis?
Yeah, one thing that we observed at some time was that when we were stopping or reducing the tapering medication in our patients that were in clinical remission, many of them flared. So we start saying, well, what's perhaps clinical remission is not enough. So we start looking at what we'll say ultrasound activity. So we start to ultrasound mainly hands and feet of all our patients with rheumatoid arthritis and psoriatic arthritis that were in remission. And we found that a high percentage of them, almost 40% of them, has still some activity on the ultrasound. So they were positive. They have positive power Doppler that indicating that there were some residual inflammation there even though the patients were asymptomatic and they were not complaining. So we followed those patients up, and we realized that those patients had, even without changing treatment, they had 11 times more risk to flare in the following 6 months than those patients that were in what we call also ultrasound remission. So we're not only in clinical remission, but also ultrasound remission. So what we are doing now is we, before tapering any drug, any treatment, we are doing ultrasound to see whether the patients are in ultrasound remission as well. And if they are not, we do not increase treatment, but we do not start our tapering, because we know that the risk of flaring is very high. So we are still with that investigation ongoing, but that was what we found. So we see ultrasound as an extension of our clinical examination. It's not that is contradiction, but it's a kind of extension of that. So we use it as very often when we have doubts, but also when we find patients that are in clinical remission.
Yeah, I think that ultrasound is an additional tool for our clinical practice in order to decide better in patients if you have some doubts about the disease activity, etc. But based on the recent data of nail ultrasound in psoriatic arthritis, what do you think is the role of nail ultrasound in psoriatic arthritis?
Well, I think it's very useful. I think it's, we have done some research related to that. Also, not only looking at the nail, but also looking at the entheses. As you know, there are entheses also in the distal interphalangeal joints. And we found that those patients that have nail involvement, those fingers that have nail involvement, they have an increased prevalence of enthesitis in that extensor tendon in that finger. So I think that that's something that we want to follow up, because that might be one of the ways that the inflammation initiates in this patient, and that might be the explanation why patients with psoriasis and nail involvement are at an increased risk of developing psoriatic arthritis. So I think that's something that is important. And also I think it's a useful tool to assess the response very early, because you can see changes in the ultrasound before you see changes in the from the clinical point of view. So I think there is a great role for the ultrasound there as well.
And we have a high demand for ultrasound use in our clinical practice. I mean, we as rheumatologists. But people say, my colleagues, they say, well, it's a very cheap exam, clinical imaging exam. It's cheaper than tomographies or MRIs, etc. But it's very expensive to purchase an ultrasound.
Yes.
I think we are in the middle. We are in the middle, and some other new rheumatologists, very young rheumatologists, they always are trying to decide and to hear the opinion of the oldest rheumatologists. How important it is to have an ultrasound or start a practice of ultrasound in our daily practice?
I think that at least to understand it as we understood the X-rays is very important. Now most of the training programs everywhere have an ultrasound training. And also we at PANLAR, we are with the ultrasound study group, we are developing a course for training in ultrasound. So I think as part of the training, that's very important. And also I think that it teaches you a lot about the anatomy of each one of the joints. The people that is trained in ultrasound knows very well all the muscles that are moving our shoulder, And I think that's a very important part of the training. So I think that, yeah, you're right. Probably to buy an ultrasound just for the rheumatology unit is too expensive. We share our ultrasound with other specialties, and I think that's the way to go. So you don't need one to use it 100% of the time, but you can share it with some other. But I think that every young rheumatologist should be trained on ultrasound, musculoskeletal.
Yeah, right. Thank you very much for your answer. We know that psoriatic arthritis is often preceded by psoriasis. It's very common to have psoriasis first and then musculoskeletal symptoms of psoriasis, psoriatic arthritis. An important and answering question is whether treatment of psoriasis might influence the development of psoriatic arthritis. This is very common. People, why do I have to treat my psoriasis? In treating my psoriasis, how can I block in the future the appearance of all the musculoskeletal symptoms of psoriasis? You included patients on a variety of treatment with psoriasis and also with psoriasis without psoriatic arthritis at your hospital. I mean, if I'm sure. If I'm not sure, in a retrospective cohort study, some years ago.
Yeah.
Which treatment reduces the likelihood of the patient developing psoriatic arthritis? Which are the best treatment too?
Yeah, what we did, well, we studied those patients treated with topicals, conventional DMARDs and biologic DMARDs, and we followed them up. Those were patients with just psoriasis, and we found that patients that were treated with biologics had a lower incidence of psoriatic arthritis. So I think there is only one other study that looked at that, but it was an uncontrolled study. So this, I think that's something encouraging, and I think it's important, but we'll probably will need more studies to prove this, because this is a retrospective cohort, and we know there are a lot of bias in this, selection bias and some other important issues. So, but I think that, again, I was talking before, I think that is a way of looking to different ways of stopping the disease to develop, not just treating it, not only treating it early, but stopping it from developing. And I think it's the way to go in the near future. And I think that psoriasis is a great biomarker of psoriatic arthritis, because most of the patients will develop psoriasis first. And I think it's something that we should look at and see how we can stop psoriatic arthritis from developing.
That's exactly what I would like to hear from you. Where are we now, as you as a chair of PANLAR, where are we now, and how do you see things unfolding the next 10 years with new developments, not only to treat patients, but also understanding the prognosis of certain rheumatic diseases? What are the challenges, in your opinion? What do we need to do to move forward with in the areas of like therapeutics and also with the new strategies to approach patients with rheumatic disease in general?
Yeah, I think we have a lot of challenges. The first one is that even though we know the important they are and the capacity that our rheumatic disease produce, they are not in the governments and the big organizations agenda. So as we were talking before, the governments do not pay much attention to them. Nobody is trained during their medical school on rheumatic disease. So we have a huge challenge there. And also we have a shortage of rheumatologists in our region, and this seems that is getting worse and worse, because when we recently did a survey on the incomes of the rheumatologists in the region, and the incomes are very low. And when we look at different regions, almost around 15% of the rheumatologists are already that are working are on the retirement age, and another 30% are within 5 years of retirement. So I think that almost half of the rheumatologists that are around now are already retired or about to retire in the next 5 years. So, and I think that the field is very attractive, but the incomes are not. So I think that's another big challenge. And I think that what has been saving a little bit the rheumatology, I think, is that the enormous amount of research and interest that the pharmaceutical companies have put into rheumatology, and I think that keeps us going on. But I think that the big challenge is to get more rheumatologists, get more people interested in the field, and improve their income. So I think that's something. And I think that an important thing is that we have been working with patients, and I think it's the other way, because the government and the organizations pay much more attention. They listen much more to patients than to doctors. So I think that's the other challenge, and we are working a little bit on that.
Soriano, thank you for your time. Yeah, it has been a great pleasure having you and having this discussion. I hope that our listeners have enjoyed our discussion and gained some insights, and very good insights. I personally have gained some very good insights into how rheumatology in general, especially in the field of psoriatic arthritis, has developed over the 40 years. Please subscribe to CSF on your favorite podcast app, and visit the CSF site, that it's very good, to download the latest paper slide summaries, author interviews, and monthly podcasts. Thank you very much, Soriano. You have a nice day.
Thank you, Valderillo, and thank you, CSF, again, and have a nice day, and take care. Bye. See you soon.